Hello everyone, and thanks for being in this webinar, and I really hope that everyone is safe. And I can only say that it is remarkable how the dental community has adapted to these difficult times and reconsidered all the priorities and devoting a lot of time to education and also putting everything in order and trying to reorganize for a strong comeback, hopefully really soon. Unfortunately, many dentists do not use the rubber dam on a regular basis in a daily routine practice, and I can say that I understand why, because rubber dam is a technique-sensitive procedure that can be very frustrating if just one of the many tips and tricks is not known by the dentist. And I remember in the beginning I literally hated rubber dam. I tried many times and then abandoned it and then tried again. And I have to confess, I created the Rubber Dam Master course thinking how much I would have appreciated back then to have access to such a course where somebody can explain all the shortcuts, all the recipes, and all the tips and tricks to save me from all the struggle. And there are a lot of discouraging factors. For example, one of the first discouraging factors, it is enough to use a low quality rubber dam sheet that keeps on tearing, and this is usually the first moment when any dentist can be pushed to give it up quickly. That's why I consider that the quality of the rubber dam sheet is crucial. And I have to mention that I'm using non-latex rubber dam sheets. They have amazing elasticity and more resistance to tear than the latex ones. And also a nice texture. It's quite important for the patient and for yourself to work with a sheet with a nice texture. And also you don't have to be concerned about allergies to latex. Let's talk about other discouraging factors. For example, not knowing which clamps to use and traumatizing the soft tissue, or not obtaining a good stability of the clamp on the tooth, and eventually the clamps can just detach and fly in the room, or not obtaining a proper inversion, and eventually the working area will get flooded with saliva in the middle of the procedure. This is extremely frustrating. Imagine you work, you think everything is isolated, and suddenly saliva is invading your area. This is very discouraging. Or let's say improperly positioning the rubber sheet frame ensemble on the face of the patient and eventually blocking the nasal airways, or having the lower part of the frame pressing the chin of the patient for a long time. This is quite painful. This can be discouraging for the patient, and if the patient will not accept the treatment, the dentist will be discouraged as well for the next time. And rubber dam can also be time consuming, of course, if not mastering the proper workflow. And I can go on, and I know that it is hard for an experienced dentist, one who was used to work without rubber dam, to switch working completely with rubber dam. I think it's much easier for a student. But now, since I have the chance to discuss on this topic with many dentists because of the online course, as a conclusion, I noticed that after few successful episodes are accomplished by the new adopters, this is triggering a nice and healthy addiction to what I think should be the stage and the decor for proper restorative dentistry. Why do I think rubber dam is important? Now, amongst many reasons that I'll mention here in this presentation, one seems to be more important to mention in the context of what's happening now worldwide. The question is rubber dam reducing the risk of infections? And I've been looking in a lot of studies related to the subject, and some are mentioning as a conclusion, and I quote, that minimal airborne contamination if a rubber dam is used. And this is also in the guidelines for the infection control in the dental healthcare settings that was published recently by CDC, and it is mentioned, of course, amongst many other recommendations, that the use of rubber dams and high volume evacuators are considered to be appropriate work practices, precautions that always should be followed during dental procedures. I'm coming to support this with everything I can in my presentation and show from my perspective how I pushed the rubber dam to the maximum in terms of reducing the airborne contamination. What we know is that indeed, during many dental procedures, the use of a rubber dam will eliminate all the contamination arising from saliva and the blood. Basically, if the rubber dam is properly placed, saliva and blood are not involved in the operative field. I go back to this photo. You have saliva, you may have some bleeding from, especially if you have class 2 old restorations, overhanging restoration, you may have some bleedings from the gums. If you properly place the rubber dam, saliva and the blood are out of the equation. So, and here I'm quoting again from the article, the only remaining source for airborne contamination is from the tooth that is undergoing treatment. And this will be limited to airborne tooth material and any organisms contained within the tooth itself. So with rubber dam, we eliminate saliva and blood from the equation and we only have the tooth. But of course this is not enough and you need to evacuate as much airborne contamination as possible before it escapes the immediate treatment site. And I quote again, the use of a high volume evacuator has been shown to reduce the contamination arising from the operative site by more than 90%. But from a practical point of view, I hope that nobody needs studies and articles to agree that the suction is more efficient if it is applied in a controlled and contained area focused only on few teeth that are exposed to receive the treatment. This is extremely obvious. Other than the advantage of reducing the risk of infections, just for the sake of the adhesive dentistry, we must avoid the contamination with blood and saliva of the areas where we want to proceed with the bonding, for example. And most of the time, the margins of the preparations are placed subgingivally. So if you want to see these margins and evaluate the fitting of the restorations, the veneers or the crowns, or let's say just to properly adapt composites, then you have two choices. First, use the rubber dam and properly expose the margins, like in this case. Or the second one is to place retraction cords. From my experience, retraction cords can be more traumatic than the rubber dam and clamps, and it is enough that we use them when we do the impressions. But at least for me, cords can be more time consuming, and with cords you can even cause more bleeding that which might be hard to control. I prefer to use rubber dam because I'm sure that bonding and adhesive material will properly condition the surface and no contamination with saliva and blood will take place. I mean, look at this case. Although I had some bleeding from the gums, once I'm placing the rubber dam, everything is clean. I can sandblast, I can remove the excess of the temporary cement, I can do all the steps from the adhesive protocol, and everything is clean. I see the margins, and I don't leave with the fear that anytime saliva can invade my area. I control the situation. It's not a situation controlling me. I can just isolate and place in the bonding, and look how nicely the veneers are delivered. I have control on the fitting. I can wipe the excess of the cement, and I can cure. If we see the margins, we have a feedback and we can control in real time and evaluate the proper fitting of the veneers or crowns before and during the delivery. It's the same, I can control the situation, I can evaluate the fitting of the restorations. You can easily clean the excess of the bonding material. Basically, the excess of the cement will be on the rubber sheet, not on the gum. So after you remove the rubber dam, everything will be clean and you will spend actually less time removing the excess. One of the biggest advantages of the rubber dam is that it is raising the satisfaction about the procedure while you are working. I mean, don't you feel better to see in front of you a wide and comfortable working area, having the cheeks and the tongue, the lips and the gums retracted and also protected in the same time? You can manipulate the rubber sheet in such a way that you can make space around the teeth. So you'll have the freedom to prep, to clean the excess of the cement, to polish, and so on. And obviously, you have more light, you have visual comfort, and again, the satisfaction about your work is definitely higher. Now, for endodontists, I hope I don't have to mention, but rubber dam is absolutely a must because they are dealing with irritants such as sodium hypochlorite that can damage the soft tissues in the mouth and can be harmful if swallowed. Rubber dam also eliminates the chance of swallowing or inhaling small restorations, small instruments, and even endophiles. And I don't think anyone wants to face this scenario. A question that I get asked a lot is rubber dam time consuming? Of course, rubber dam can be time consuming if you don't know the proper workflow, the proper protocol. Once you master the techniques, you will actually save time. However, rubber dam can significantly save time by reducing the ability of the patient to communicate. And if you have over-talkative patients like my son here, rubber dam for sure will facilitate a faster treatment. But also do the math. How much time do you save if the patient doesn't get up to rinse every 2 minutes? And remember, you have sometimes patients that are rinsing for maybe 30 seconds every time until they finish the water from the cup. So you will save time having the rubber dam on. Now, as an approach, I saw many dentists working with rubber dam, but many of them are first removing the fillings and then they clean the cavities without rubber dam, and only after this they will continue with placing the rubber dam and, let's say, delivering or directly restoring. I consider it is more convenient to first place the rubber dam before doing anything. And here I'm mentioning again the importance of this approach in the context of reducing the risk of infections. But let's say we live in a germ-free world and you don't care about microbial or virus contamination. Just from the procedure's perspective, please tell me, isn't it better to have the cheeks and the tongue retracted and hidden under the rubber sheet to allow you a good visualization of the working field, and to have the gums retracted, to have more light? Also, to protect the patient from inhaling the grinded material and small parts when removing fillings or caries. I mean, is there any need to research for studies to agree with this? Please look at this case. There is a lot of saliva, strong cheek, and a big tongue. I really find it extremely difficult to work without rubber dam, and I appreciate the retraction provided by the rubber dam and the light and the comfort and so on. But going back to the case, one of the biggest advantages of prepping with rubber dam on is that you have the chance to properly do the immediate dentin sealing, again relaxed, without the permanent fear that some bleeding might interfere at any time. And of course, you have to refine the occlusal preparation and provide enough clearance for the ceramics, and you need to remove the rubber dam to evaluate that in relation with the other teeth. However, for Scanus users, I'm soon producing and publishing as a bonus in the Rubber Dam Master online course a module where I'm explaining how to prep with the rubber dam on, scan with the rubber dam on, even putting the temps, then remove the rubber, and how we manage to have perfect onlays in terms of occlusion. There are a lot of tips and tricks to be considered in this approach. Maybe many of you they know how to do it, but for ones that they don't know, I will soon launch this bonus. Going back to the case, the same goes in the delivery session, same rubber dam setup, and everything is bonded under the same isolation formula. If I don't tell you, you might be tempted to say that this photo belongs to the same session, like for example this photo, but basically this is the preparation session and this is the delivery session. But I'm trying to say that actually if you know your protocol, if you know your workflow, you will place the rubber dam every time the same, because you know that you can rely on a specific formula, on a specific technique. So of course I'm delivering the ceramics one by one. I respect all the steps in the adhesion protocol. I'm even finishing the composite on the last tooth, and the case is finished. But look at this case, and I'm repeating myself here. Rubber dam before. I don't touch anything. I place the rubber dam, the gum is retracted, and I even use the ProfiJet and scaling after I place the rubber dam, because at least I don't face any bleeding of the gums while doing this. I mean, just look at the patient. Of course, you will expect some bleeding, even if you use the syringe with air or water. Not to mention if you do a scaling, you'll have a lot of bleeding. Everything is clean and I can go ahead and prep deep margins, and the fact that I placed the rubber dam before helped me stabilize it in the sulcus with the floss, and as long as you don't touch it with the burrs, it will stay there even if you extend the prep really close to the inversion area. You cannot see the floss here because basically I'm hiding the knots towards the palatal side. Not only that the photos are nicer, but also the knot will not be in the way of the burr while prepping so deep. So you can already proceed to restore, and you can continue in the setup as much as possible. This is the whole idea, to do as much as possible with the protection on. You can even do the polishing, and even if you do it on the palatal side, of course you have to remove the rubber dam and refine the palatal side in terms of occlusion adjustment, but this time is minimized as much as possible. Let's evaluate another case and show you why I consider it is more practical to place the rubber dam before and not after or during the procedure. And many dentists will have here a different approach. Let's say they know they have to prep for crowns, and then they start prepping, like exploring, saying, let's see what I will get from the tooth after I prep. Do I need to redo some fillings? Do I have to clean some caries? Never mind, I will start prepping and then I will see. But you know from your experience that most of the time you need to replace the old restorations and even restore with posts and reinforce the teeth with post and build-ups. And it is very obvious sometimes, and you anticipate that you need to restore. So my conclusion is rubber dam before whenever I can. There are situations when you can't, when you have to remove bridges or in many other scenarios, but I'm using open rubber dam, and I'm explaining in the course why I think open rubber dam is much better in terms of retraction and protection for the patient than all the normal retractors we know. But just a note, I am switching to full isolation when I deliver the restorations. For example, in this case, we finished the veneers, and I prefer to do full isolation, exposing completely the tooth structure. And usually what I'm doing, I'm delivering the restorations 2 by 2 using 2 clamps, and this is how I finish the case. Going back to the initial case, if you place the rubber dam before for the preparation and restoring purposes, you have a huge advantage. The convexity of the non-prepped teeth will help you insert and glide and stabilize the rubber sheet in the sulcus. But if you prep before, there is no way you can place the rubber dam like this, properly inverted and stabilized, unless you are using clamps. But in this scenario, replacing fillings and placing the posts and doing the build-ups for all teeth, for example, like I did in this case for all the 4 anteriors in the same time, will be more complicated because the clamps will not let you do this. So why not to have this approach? First thing, of course, you have to remove the overhangings because you anticipate the fact that you need to facilitate the gliding of the rubber sheet, and then proceed with the isolation. Now you can start exploring. You can remove all the fillings, you can clean the caries, even do some initial prep. And basically why I'm doing the initial prep, one thing is to, like I said, to extend the time working with the rubber dam on, with the protection on. But also this is the only way to properly evaluate the remaining tooth structure, because I do the preparation from the outside, I remove the fillings from inside, the old fillings and the caries, and then I can properly evaluate the tooth structure, and I can decide if I need to place posts or not and build-ups. And just a short note here, I know that all the endos have been properly done or redone. So I'm doing the build-ups. Notice that the rubber dam is still stabilized in the sulcus with the help of the floss ligatures, and I can even continue with the initial preparation. And as long as you're not going too much subgingivally, the rubber dam will stay in place, only being held by the floss. Please have a look and confirm if you think that the suction is more efficient in this case. You don't have the lips, you don't have cotton rolls, and the suction, the active surface of the tube is not blocked by anything, and it has maximum efficiency. So you have to extend to the maximum the time when you work under absolute isolation, avoiding any contact with saliva and blood as much as possible. Of course, you have to remove the rubber dam, refine the margins, check the occlusal clearance, and take the impression, but this time is already reduced. It's not the same to work 2 hours without rubber dam or maybe 5 minutes or 10 minutes without rubber dam. For the delivery session, I'm using the same setup, but now you can agree with what I said before, that I can't place the rubber dam as easy as before. Now I need to use the clamps to hold the rubber sheet in place and invert it in the sulcus. And this is actually an old case. I was using a B5 butterfly clamp from Brinker set. The disadvantage of this clamp is that the arches are blocking both sides, and basically you can't deliver 2 restorations in the same time. What I'm doing recently, I'm actually cutting the clamp in 2 parts, keeping only the active part. I'm preparing one clamp for one side and another one from the other side, and I have multiple of this. And I'm exposing 2 teeth in the same time, and basically I obtain, let's say, stronger before, because if I go to the photo with the before clamps, just a second, before clamps are very nice, they look good in the photos, but the problem is that they are quite fragile. They have a fragile stability on the margins, and for example, if your assistant by mistake will hit this clamp with the suction, the clamp can detach, can jump from the margins, and if this is happening during the delivery, it's quite a disaster. Imagine you are holding the restoration loaded with adhesive material or with the cement, and suddenly the clamp is jumping and the rubber dam it's losing the inversion. So of course you'll have to stop, and you'll have a lot of things to do to repair the situation. But going back to the case, I'm placing this clamp, and this clamp was quite useful because the margins were deep, and I really appreciated to use a strong clamp to be able to expose the margins. And notice that the margins were actually properly exposed from all sides, and I was able to do a nice and clean delivery. Look how satisfying it is to see the margins and to control the situation, to evaluate the fitting of the crown, and to have the feeling of a properly done job. But going back to the initial situation, I have to mention again, why not to anticipate the problems and prepare to properly restore the support for the new crowns. Social media is full nowadays with these fashionable concepts of smile design, digital workflows, 3D scanning, CAD/CAM technology, 3D milling, 3D printing, and you can be lucky to have a very talented technician that will craft for you amazing ceramics. And I have to say, and I confess, I'm very thankful to have the access to all this, and maybe that's why I love being a dentist nowadays. But what I'm trying to say, that even after having all this, it will come the real moment when you will hold in your hand a piece of porcelain that you will have to bond on something. Now, what is that something, and how do you bond it? This is up to you, and this is a real moment. It's not fashionable, is not fancy, is not trendy, is not digital. It has to be real and responsible. Let's see another case with anteriors. Same protocol, rubber dam is placed, exposing canine to canine, and I'm explaining every detail and all the tips and tricks in the Rubber Dam Master online course. But if you noticed, even in the previous case, I'm only exposing canine to canine. Of course, in these cases, I'm only working on the 4 anteriors. But even if I have to do, for example, if I have to deliver 10 crowns or 10 veneers or 12 units, I'm still exposing only canine to canine, because first thing is overkilling for the patient to expose first molar to first molar. And also when you put the clamps on the molars, the lip is very tensioned and it's very difficult for the rubber sheet to push the lip in an upwards position and provide for you a nice and clean area next to the cervical part of the tooth. When you place the clamps on the premolars, the lip is not so tensioned and the rubber sheet has enough force to push the lip upwards and expose the cervical part of the tooth. And many times you need to do this, especially in this case, for example, where actually I need to prep next to the inversion area. But just going back, please note again that I anticipate the moment of the gliding of the rubber sheet through the contacts, and I partially remove the overhangings, and I even lubricate the contact points with the floss soaked in glycerine. But I don't touch anything else. I even do some cleaning and some Profijet after the rubber dam, not before, because I am still, again, I'm avoiding the bleeding from the gums. Then you can start exploring. You can remove the fillings, you can clean the caries, you can sandblast, you can reinforce with posts, you can do the initial prep like I explained. Here, if you noticed, again, this is an old case, and I placed the floss with the knots towards the buccal side. It's actually much better to reverse the position of the knot and place it towards the palatal, so you have more freedom to work in this area. Anyway, I'm continuing with icon infiltration. I'm doing the composites on the other teeth, and even continue more with the initial prep with the rubber dam on. The rubber dam stays in place because I have placed it before the preparation, and it was glided by the convexity of the teeth and stabilized in the sulcus. If you want to place the rubber dam now, it's quite impossible without a clamp. But anyway, don't you find it practical to have the full anterior segment restored in terms of finishing in the first session, all the direct restorations, post reinforcement, and to have everything done in the same session and in the same setup, which is protecting you from blood and saliva. And I know I'm repeating myself here, but again, with all the advantages of having light and retraction and also a reliable adhesion. When I do the delivery, I'm using the same isolation protocol. If I don't mention anything, you might be tempted to say that the photos are from the same session. Going back to the preparation session, if I show you this photo, is actually the clamps are in the same position and the rubber dam is in the same position like this photo. The difference is that now I'm using clamps, especially that the margins are deeper. Of course, I had to hide the dark tooth substrate, and also in order to hide the dark color, we decided to do a zirconia coping layered with ceramics. Why? Because we wanted to obtain the same color of the abutment of tooth number 9 to be the same like the prepped tooth number 8, to be able to do the veneer on number 8 and the crown on number 9 from the same blocks, the same level of translucency, and eventually to obtain the same color. So basically what I'm doing, I'm delivering the zirconia coping like I deliver a crown. I just do the normal etching and the adhesive protocol, and after the zirconia coping is delivered, I am of course I'm cleaning the excess of the cement, and I'm carefully removing everything from the margin of the coping to allow a proper fitting of the crown. Then this might look awkward, but actually I'm etching the ceramic, and of course you cannot use hydrofluoric acid in the mouth unless you have a really good isolation. And I etch the ceramic to provide adhesion with the next layer, which is the crown. And then I am delivering the veneer on number 8, and then I'm delivering the crown on number 9, and the case is finished, and obviously the patient is happy. Let's see another case with posteriors. What is the first thing that I'm doing? Rubber dam. Of course, I check before with floss if the contacts are allowing the sheet to glide towards the sulcus. If I have overhangings, I'm reducing them with a diamond strip, or you will see in the next case that I'm even partially removing the restoration to open the contacts and allow the sheet to glide towards the sulcus. This is a partial quadrant isolation, posterior protocol. I'm explaining in the online course every detail and all the tips and tricks about isolating posteriors, because basically the course is structured in anteriors and posteriors, and I'm explaining all the recipes, and also I'm showing live cases. But going back to the case, the convexity of the teeth will help the rubber sheet insert towards the sulcus, and also the floss ligature is more effective in pushing and inverting the rubber dam. But just imagine that you first remove the fillings and you start clean the caries, and only after that you are placing the rubber dam. Not only that here the gum will bleed, but it will be harder and you will struggle to pass the rubber sheet over the margins once the fillings are removed, and especially if you have deep margins. Please notice in this photo that I am placing the floss even on the anchor tooth, the tooth holding the master clamp. You can see here the knot, because most of the dentists, they only place the floss on the other teeth. But the problem is that if you don't use the floss on this tooth, you might not obtain inversion under the beaks of the clamp. You can obtain inversion here just by using the floss, but on the last tooth you can use the spatula on the mesial side to invert the rubber dam, but you don't have access under the beaks of the clamp. The only way to properly invert the rubber dam on the teeth with the clamp is using the floss over and under the clamp. Basically, I'm explaining in the course many times this aspect. I even have a separate module called floss ligature where I show again this technique. Is quite easy, but it's also very important, because imagine you do everything is clean, and you want to do the immediate dentin sealing on the first molar, and suddenly some saliva can come from the last tooth and invade your area and compromise your result. So having the rubber dam properly placed, you can proceed with removing the restorations, cleaning the caries, and just going back to what I said before about infection control. At least now I don't deal with saliva and blood, and the only source of infection are the teeth, or even to be more specific, 3 teeth, not 24. And the suction is focused on an isolated area. Again, I don't think that anybody needs studies to agree that in this scenario the suction is more efficient. So I try to do as much as possible with this setup. I'm doing all the direct restorations in this session. I finished the molar. I'm also doing the restoration on the premolar, and recently I'm prepping and even scanning with the rubber dam on. But there are some things to take into consideration to be able to do it in this way, and also to anticipate the fact that ceramics will be involved in the process. I will soon launch a module that I will add in the course for free, explaining all the tips and tricks about this approach. For the delivery session, rubber dam goes in the same position. If I don't tell you, and if I show you this photo, and let's say one photo from the preparation session, you might be tempted to say that they belong from the same session. But actually here I am in the delivery session, and I'm delivering the onlay. And of course I respect all the steps from the adhesion protocol. Just a small trick here, basically I'm using super floss just to be able to wipe the excess of the cement before curing from the contact points. It's much easier to clean in this way. So the delivery, and actually I'm trying to do as much as possible with the rubber dam on, with the protection on. I'm cleaning the excess of the cement. I even do the polishing, and of course I anticipate that I have to do some occlusal adjustments and to polish again, but I did as much as possible with the rubber dam on. And I'm showing you this photo, which is immediately after I removed the rubber dam, just to show you that proper placement of the clamps and floss will not cause a significant harm to the gums. Many dentists are asking, okay, but how do you place the rubber dam if you have deep margins? And of course you evaluate the case and the x-rays, and you see and you anticipate that you will have deep margins. But now I'm not talking about the situations when margins are so deep that you have to do crown lengthening. That's a different topic that I will explore in one of the future modules, and I will explain how I integrate the crown lengthening and the rubber dam in the same time. But now I keep on insisting on the importance of placing the rubber dam before, although I have deep margins. Even in cases like this is bread and butter of simple daily restorative dentistry, class 2 composites. Would you explore completely removing the fillings and cleaning the caries, or limit the time working exposed to saliva and blood and place the rubber dam before? You just partially remove the overhangings, break the contact, but that's it. A minimal intervention prior to the insertion of the rubber sheet. Basically, if you have an overhanging filling, we can use this in our advantage, because the overhanging will basically push the rubber dam, and the rubber sheet will fall under the overhanging, and it will glide towards the sulcus. So only after the rubber sheet is properly inverted, I will start removing the old restorations and cleaning the caries. I see what I'm doing. I don't have any bleeding here. I have light, and I can properly clean everything and continue with restoring, and I can finish the case. And again, I do as much as possible with the rubber dam on, even the polishing, although I anticipate the fact that I have to remove the rubber dam and do some occlusal adjustments, but at least I reduced this time to the minimum. Look how nicely the protocol is from start to finish. So basically we have extended the time working with the rubber dam on, because it's not the same to work 1 hour or 2 hours without the rubber dam, or 5 minutes without the rubber dam. As a conclusion, the use of the rubber dam and high volume evacuators is a precaution that always should be followed during dental procedures. That means that the first line of defense against airborne contamination is working at a full capacity, not being blocked by tongue, cheeks, or cotton roll, or even overloaded with saliva. And we should use rubber dam regardless of the fact that we're facing or not a worldwide pandemic. After all, it's really also about us. We are spending 8 hours or even more per day in one room, and it's up to us what we are breathing. From a business perspective, the patients will trust more a dentist who will reset all the protocols in terms of infection prevention. And anyway, what's happening now in the world is a wake-up call for us to practice a more responsible dentistry. Thanks everyone for taking this time to listen to this presentation. I really appreciate that, and I will be happy to answer any question. Just reach out to me on my social media, where we can keep in touch. And I hope that many colleagues can benefit from this webinar, and they will be motivated to work with rubber dam. And of course, you will find more informations and many tips and tricks in the main course available online, where you have everything structured and organized in super explanatory video chapters, which are not only showing rubber dam. I'm not just placing the rubber dam and then I take a photo and that's it. I am actually presenting tons of daily work scenarios where rubber dam is, in fact, like I like to say, the stage and the decor for proper restorative dentistry. And the course can be attended from any device in the same way you watch Netflix, for example, and it can be accessed lifetime. It is an online platform where every dentist can comment and ask any question, and I will answer, or even if the topic requires more information, I will produce additional content that I will add it in the course as a bonus for free. Nowadays, I'm offering the course with 30% discount to support all the colleagues in these tough times. In the end of this presentation, I'm going to let you see a fragment of my favorite part of the course, which is actually a bonus that I added after I finished the course, and it is explaining in the smallest detail the ergonomy and the position of the hands while placing the clamps. Please enjoy it, stay safe, and let's stay in touch. Thanks everyone, and see you online. When we talk about rubber dam ergonomics and how to obtain an easy and relaxed workflow, the most important thing is the position of the hands while placing the rubber dam setup. I have watched and observed my colleagues placing the rubber dam, and although they were following everything they have learned from the Rubber Dam Master online course, I still noticed that they struggle when performing the isolation, and I tried to understand the reason behind this. I have noticed that the struggle was due to the position of the hands in relation with the position of the eyes while placing the clamps. This is equally important as all the techniques and all the tips and tricks described in the Rubber Dam Master online course. For an ergonomic isolation workflow, handling the components should be fast and precise, not only for you as a practitioner, but also for the patients who might be concerned about your skills if they notice a considerable struggle from your side. Let's focus on the position of the hands while placing the clamps and describe all the details. I've produced this explanatory video using 3 synchronized cameras to show you the action from different angles. One is a general view, so you can see the position of the hands and posture. Another one is an upward view to show a close-up of the patient. And the third one is a camera attached on my loops, filming all the details magnified intraorally. Let's start with placing the master clamp on the lower teeth. As I have mentioned in the course, I am already attaching the clamp in the rubber sheet in the perforated hole. I find this to be the most ergonomic way to place the setup. You have the rubber sheet frame clamp ensemble prepared on the chest of the patient, so you can conveniently collect it from here with the help of the forceps. Frame, sheet and clamp go together one time in the working position. Right hand is holding the forceps, left hand is controlling the clamp, pressing the arch to the distal. A common mistake that I see is holding the forceps from up. It looks like the natural way to grab it. But the problem is that when you're actually placing the clamp, your entire arm is in an unnatural and unpractical position, and you can't see the clamp because your wrist and hand are blocking your visual access. It is more practical to grab the forceps from down. Your arm is relaxed and close to the body. Holding the setup in this way, you will approach the area to isolate, so you are using both hands at the same time to manipulate the frame, sheet, clamp, forceps setup. Your wrist and hand will not block your visual access to the forceps and clamp. Instinctively, you may want to go directly towards the anchor tooth, but I advise you not to do that, because you will push the rubber sheet directly against the buccal commissure, and the sheet will be very tensioned next to the clamp, therefore it can detach from the wings or tear. It is better to push the clamp in the middle of the mouth, and only after reaching this position, both hands go together to the right or to the left, searching for the anchor tooth depending on the quadrant you want to isolate. While you are doing this, the index or the middle finger of the left hand is controlling the position of the clamp, and in the same time it is pushing and retracting the cheek to the left or to the right, again depending on the approach quadrant. Please notice that this time, because you are moving from the middle of the mouth towards the anchor tooth, you will now have enough reserve of rubber material engaged between the buccal commissure and the clamp, so the rubber sheet will not be tensioned. You have visual access between the left hand and the right hand. Nothing is blocking your eyes to see the clamp, so you are in perfect control. You have a relaxed body posture, and the hands are also in the most ergonomic position. Then you can attach the clamp and proceed with exposing the teeth and inverting the rubber dam with a floss ligature, as I described in Posterior protocol chapter, inversion module, and all the bonuses from the Rubber Dam Master online course. Now let's talk about the position of the hands when you isolate upper posteriors. Just to review a small detail about the position of the clamp rotates to end up with the arch oriented to the distal. So you have to anticipate that and position.